not obese. Some people have sufficient physical activity. Some people do not have sufficient physical activity. Some people smoke. Some people do not smoke. So, in our population, would you please join us? Please come closer. Yeah. You too, please. Please. Yes? So, we have a study population, and in this study population, some people are exposed, are categorized, are classified as exposed, and some others are classified as not exposed or unexposed. And we follow them, follow all the study population, those who are exposed and those who are not exposed, to see if they develop the disease or not. And then compare the rate of disease development among those who are exposed with those who are not exposed. Okay? So the design is prospective. We classify people. Imagine that in this class, we classify all of your classmates into those who have sufficient physical activity and those who do not have physical activity. And after 20 years, and follow you for 20 years, and after 20 years, we see if there is any difference in the rate of, let's say, cardiovascular diseases among those who have sufficient physical activity and those who do not have sufficient. So we follow our study population for a while, maybe short periods or maybe long period, to see if the disease development is different between these two groups. This is the study, this is the design of cohort study. Okay? In this study, we can actually calculate risk. But in the case control study, we do not have a lot of money. We cannot wait for, let's say, 10, 20 years to see if the disease develops or not. So, we have an alternative design as case control study. We can go to the hospital and select some cases, for example, some breast cancer cases, and select some controls. Controls are those who do not have the disease of interest, for example, breast cancer. Okay? And ask about the past history of exposure. We ask them if they have had exposure to the exposure of interest in the past or not. Okay? So, in case control studies, we are asking about the exposure in the past. That's why it is called as retrospective study. Retrospective. I cannot continue my these. So, if you don't want to come to class, if you want to leave the class, please leave now. So, case control study is alternative design for cohort study. And because I said yesterday that in case control study, we cannot actually calculate the risk, but we can calculate another measure of association, which is odds ratio. Odds ratio, where are you? Come in, sit down please. The measure of association which is odds ratio. Odds ratio can estimate risk ratio in cohort studies, and if the disease of interest is rare, it would be a good estimate. Okay? We talked about how odds ratio can be a good estimate of risk ratio when the disease is relatively rare. So, if you see in the design of cohort study, we have a population, and now all population are disease-free. So we follow the people without the disease. First of all, we classify them as exposed and not exposed, and then follow for a while to see if disease is developed or not. So we want to actually examine, please remember that we want to examine if there is any association between the exposure and the outcome. So our question is, if exposure is a risk factor or a protective factor for outcome or not. So cohort study, the direction of our inquiry is in the same direction as the time, is parallel to the time. It means we go from exposure to the outcome. But in case control study, as you see, we have cases, we have controls, and ask about the history of exposure in the past from both cases and controls, and compare the proportion of exposure in the past in cases and controls. So the direction of our inquiry is in the opposite side of the time. That's why we call case control studies as retrospective. So, is it clear? Yes. Is the design clear? Okay. So, as you remember, and we reviewed yesterday, we first select cases. Cases are those who have the disease, let's say, and actually then we select controls. Controls are those who do not have the disease. So we have A plus C number of cases, B plus D number of controls, and these are proportion who were exposed. A over A plus C, and B divided plus B plus D. And what was the measure of association for case control studies? What was the measure of association? It was odds ratio. So how can we investigate if there is any association between the exposure and the outcome? Let's see this hypothetical example of a case control study of coronary heart disease and cigarette smoking. We compared 200 cases with 400 controls, and among cases, 112 have exposure, they smoke, and 88 do not have exposure, which means do not smoke cigarettes. And among these 400 controls, 176 smoke, and 224 do not smoke. So, how can you calculate odds ratio? How can we calculate odds ratio? What's odds ratio in this case? Based on what you learned yesterday. What was the formula for odds ratio? Who remembers?
A divided by A plus B.
A
Divided by A plus B?
No.
A divided by A plus C.
Ratio would be 112 multiplied by 224 divided by 176 multiplied by 88. And the odds ratio is 1.6. How can you interpret 1.6?
It is more.
It is more than
1.6%.
Yeah, it is more than 1. So it means that smoking
More
is a risk
vulnerable.
factor for coronary heart disease. Okay?
1.62
How much?
times.
Times more, 1.6
1.62
1.6
times.
times. Okay? So again, our interest is to see if exposure has any effect on the outcome or not. Okay? So we interpreted that cigarette smoking has an effect on coronary heart disease. How much is it?
1.6.
1.6. Okay? So there are some advantages for case control studies. I said that in some cases, in some diseases, we have a very long latent period. It means that if you want to, let's say, actually do a cohort study, and if the rate, if the incidence of that specific disease is, let's say, 10 per 100,000 cases, population, as we have generally, for example, for some cancers, the incidence rate is 10 over 100,000. Okay? So let's say we want to have 100 cases. How long should we wait to have 100 cases? The rate is 10 per 100,000 per year. So we have to wait 10 years to have 100 cases. Okay? So we need to have a long time to conduct a cohort study, to have enough cases to be able to study the actually association of our exposure of interest with the disease. But there is an alternative. In case control studies, we can go simply to the hospital and select 100 cases of that specific disease that have already admitted in the hospital, that have already registered in the hospital. So for the diseases with long latent period, case control study is appropriate. It is also simple in design and conduct, especially in rare diseases. And there is a possibility to investigate multiple risk factors with a single disease. When we are going actually to study risk factors for breast cancer, we can investigate if they have had sufficient physical activity, if they have had smoke, if they have been obese, and many other risk factors, several risk factors in relation to a single disease like breast cancer. So these are advantages for case control studies compared with cohort studies, for example. But the first step in doing a case control study is actually definition of cases. Who is the case? What's the diagnosis? When we say, for example, when we want to study coronary heart disease or cardiovascular disease, who has cardiovascular disease? It's very important to have a clear and explicit criteria for the diagnosis of that specific disease. definition of case. The definition of case should be simple and accurate. Should be simple, actually to be able to diagnose with actually without any problem, and should be accurate because our criteria, our definition should separate cases and non-cases accurately. When we are going to study cardiovascular disease or coronary heart disease, it is very important to separate between those who have coronary heart disease and those who do not have coronary heart disease. Okay? If our definition is not accurate, there may be some misclassification. But what is the effect of misclassification? You know, imagine that we have a disease which has a very strong association with our exposure. So all of who have the disease are exposed, and all of who do not have the disease are unexposed. It means that there is a very strong association between our exposure and the interest. But if our definition is not clear, and cases and non-cases are misclassified into actually wrong categories, wrong classes, we may have this one, which means some cases are classified as controls, and some controls are classified as cases. So there would be a misleading result, which means that there is no association between cases and control in terms of exposure. So while there is a very strong association, we cannot detect this association. And this would be a misleading result about the effect of this exposure on the disease. So misclassification is a very serious problem in case control studies if our definition is not accurate. Okay? To proceed, please let me share the concept of target population and source population. What is target population? When we are going to conduct a case control study, the target population is the actually whole population that our results from that specific study will be generalized. So the whole population, for example, in Kish Island, would be our target population. If you want to study a case control study on breast cancer, the target population is all breast cancers in Kish Island. Okay? But the question is, if all of those breast cancers are accessible for us to study on them, sometimes no. Because some of breast cancer cases in Kish Island go to, let's say, Bandar Abbas, go to Tehran, even go to Dubai for following their treatment. So, when we go to actually health department to see the list of those breast cancer cases in Kish Island, we do not find the name of some cases. So the source population is the subset of the target population that we have access to that are included in the list of, for example, health department in Kish Island. Okay? And our sampling will be done from that source population. As much as source population is the same as target population, we do not have any error, any selection bias. And if source population is different from the target population, some errors will be introduced in our study. Because some cases are not in the list, and some cases do not have the chance to be included in our study. The sample is the number of cases that we select to be included in our class. For example, if in the source population there is 1,000 cases, maybe we choose to select 100 cases to be included in our study. So these 100 cases are our sample. That 1,000 cases are the source population, and the whole cases in the Quiche Island is the target population. So, in our sampling for case control studies, when we are selecting cases to be included in our case control study, we should make sure that the source population and the target population are the same. Okay? So, let's move to the potential sources for selection bias. There are two main potential sources for selection of cases in our case control studies. The first one is hospital. We can go to the hospital and see if there is cases to be included in our case control studies. For example, in the case of breast cancer. It is simple because the lists are available. The list is available in the hospital. There is accurate because they have to diagnose breast cancer cases accurately because they want to treat them. So the diagnosis is more or less accurate. But there may be some selection bias because some of them do not go to the hospitals of Quiche Island for their treatment. And if those who leave the Quiche Island and follow their treatment, for example, in Tehran, may be different from those who stay in Quiche Island and follow their treatment here. So there may be some selection bias, there may be some errors. If they are different in terms of the exposure of interest, our result from case control studies may be misleading. Another source for selection of cases is population. How population can be a source? Population can be a source if there is any registry, any population-based registry. For example, Health Department in Quiche Island may register all cases of breast cancer, even those who have left Quiche Island for their treatments may come back and be registered in our registry. So, if there is a registry, we may have this chance to select our cases from that registry. So, the risk of selection bias is lower in this case. For population-based cancer case control studies, the risk of selection bias is lower. But unfortunately, there is underreporting in our registries. Sometimes there is no registry for some cases or for some diseases. So we do not have this chance for all case control studies to go to the population and select cases from the whole population. In terms of selection method, there are two methods for selection of cases: prevalent case selection and incident case selection. In prevalent case selection, the cases are selected from the people who have had the disease for a while. But in incident case selection, we include only newly diagnosed cases. How? Please look at this schematic figure. Sorry. when we go to the hospital or go to the registry to select our cases, we are here. Let's go 10 years back in time to see which scenarios may actually happen to our cases. The case number 1 was diagnosed 10 years ago, and at the time of study, at the study time, she is still alive. Okay? Case number 2 was diagnosed 10 years ago, but 2 years later, she died from breast cancer, for example. Case number 3 was diagnosed 3 years ago, and she's still alive. Case number 4 was diagnosed 3 years ago and died 2 years later. Case number 5 was diagnosed 5 years ago and she's still alive. And case number 6 was diagnosed 5 years ago and died 2 years later. So, which of these cases have this chance to be included in our study? Which one? First, case number 1, 3, and 5. So, these cases do not have the chance to be included in our study. And if the exposure of interest has a strong association with the severity of the disease, those who have already died and do not have to be included in our study may have been exposed. So, this method of case selection would introduce a very serious error in our study, because some cases who have been exposed are systematically excluded from our study. They have been systematically excluded from our study, and only we actually include simple and actually mild cases in our study. So this kind of selection method will dilute the measure of association that we are using to show the strength of association between exposure and outcome. What can we do? We can choose another method for case selection, which is incident case selection. We can start here, right now, and ask our doctors in the hospital, please, if you diagnose a new case, please let me know to be included in my study. So, in this scenario, all cases, not only case 1, 3, and 5, will be included in the study. Okay? We say this method of case selection as incident case selection.
No.
What is the advantage of this method?
We can add all.
The chance of error, the chance of selection bias is lower. What is disadvantage? It needs time. And the prevalent case is much easier. We need to wait to collect all cases that we need for our analysis. So, we have to choose based on the amount of error that we expect from prevalent case, selection. Okay?
Sir,
So,
sir, in the last prevalent case, you said that we will talk about the past one, the past patient who suffered from that disease. Okay, so you included 136, 135 that was alive. Okay, that was alive, and in the incident case, new patients will be included.
yeah.
Okay, so we will add all the patients. So why we study only the one who are alive in prevalent case, sir?
Because you know that in case control studies, I mentioned that we have to, for example, ask the patient from the past exposure.
Yeah.
And if the patient is not alive, how can we ask them, for example, what was your behavior in the 10 years ago? Okay? So we have, in some cases, we have to include the live patients, live cases. Okay?
If he has a history, it's okay. We can see.
Yeah, sometimes we can go back and see their, for example, health records. In this case, we do not need to see, only actually include the live patients. Yes. So the first step is selection of cases. And the second step would be the selection of controls. After we select our cases in an appropriate way, we have to select another group, actually the group of comparison, which is control group. How can we select control? The most sensitive step of case control studies is control selection. Because control selection is seriously prone to selection bias. So it's very sensitive. Selection criteria for the control group should be the same as cases, except for lack of disease. The control groups do not have the disease. So the only difference would be lack of disease. Other criteria should be the same. Okay? And controls should be selected in similar way as cases. If you go to hospital and select cases, the controls should be selected from the hospital. And if you go to the population and select cases from the registry, we should select cases from the population. Okay? So we have to select controls in similar way as select cases. I said that control selection is very important, so the name of or the label of case control studies are based on the way we select controls. So if we select controls from the hospital, we call it hospital-based case control. And if we select control from population, we call it a hospital-based case control. And hospital-based case and population-based case controls have more quality compared to hospital-based case control because they are less prone to error of selection bias that we get familiar more in the actually next sessions. What is the primary case control versus secondary case control? If you first select cases and then select controls based on the way the cases are selected, the study is said primary case control. Sorry. If you first select cases and then select controls based on the way you select controls, it is secondary case control because you first select cases and then you select controls that are the same as cases except for the disease. But if you select the population, for example, Kish Island, and select both cases and controls from the population, your study is said primary case control. And primary case control is in most cases equal to population-based case controls. So primary case control and population-based case controls are the same. And secondary case controls are mostly equal to hospital-based case control. Okay? So we have hospital-based case control versus population-based case controls. We have primary case control versus secondary case control. There are some important points that should be considered when you are selecting cases from hospitals. The first one is that controls should be selected from the population that cases come from. Which means if you actually go to a hospital, for example, subspecialty hospital, and select your cases, let's say breast cancer cases from that hospital, and these breast cancer cases are coming from the whole population of the island. You cannot go to the actually, let's say, orthopedy ward and select controls from that orthopedy ward that its cases of orthopedy ward actually are coming from the neighborhood around the hospital. So you have to select controls in the way that you make sure that controls are coming from the population that cases are coming from. Okay? The second point is that controls should not come due to the same reason as cases or to a disease that is close to it. For example, you want to study the association of smoking and lung cancer. So your cases are lung cancer, and controls should not actually selected from emphysema cases, because smoking is the risk factor for both lung cancer and emphysema. And when you are investigating the association between exposure and outcome, which is smoking and lung cancer, you will see that the prevalence or proportion of the smoking is the same between lung cancer and emphysema. And you may conclude that smoking is not associated with lung cancer because you have selected your controls among the wrong group. So, controls should not come due to the same reason or case as cases, or due to a disease that is close to it, which is emphysema, which is close to lung cancer. Okay? The disease that the controls are selected from should not have common risk factors with the disease of the cases. I explained about it. And controls should be selected from multiple diseases instead of a single disease. When we actually select cases, when we are going to select controls, for example, for cases who have breast cancer, it is not a good idea to go, for example, to gynecology ward and select controls just only from, for example, those who have cervical cancer. If you want to dilute the error, if there is any error, it is a better idea to select controls from several diseases, from, for example, multiple diseases instead of just a single disease. So, the selection of control in case control study is very important and should be done very carefully to make sure that they are coming from the same population, they do not have common risk factor with the cases, and there is no selection bias. The most important and the most serious problem that we have in case control study is the selection bias that is coming from wrong method of selection of controls. So it is very important. So the first step was case selection. The second step was control selection. And sometimes we have matching in selection of cases and controls. Sometimes there is very important risk factors that we are interested to be identical between cases and controls to make sure that that variable, that factor would not confound the association that we are going to investigate. Okay? For example, age, sex, and race are very important confounders that can confound every actually association. So, for example, if we select a case of 50 years old for actually study actually breast cancer, we should select a control of 50 years old to make sure that the only difference that exists between cases and controls is the exposure of interest. And age cannot confound this association. You will see what is confounded in the next session. But in this case, we match cases and controls in terms of age. In this way, we force case group and control group to be identical in terms of age distribution. For example, if the average of age in cases is, let's say, 60 years old, the average of controls, the average age of controls is also 60 years old. So we can make sure that this is not the age that confounds the association of interest. So we match cases and controls in terms of age. How do we do that? There are two ways of doing matching between cases and controls. Individual matching and group matching. What is individual matching? Individual matching is actually selecting one or more than one control for each case, which is identical, which is exactly identical in terms of that matching variable, for example, in terms of age. If we select, for example, a man of 50 years old for cases, as case actually, we would select a man of 50 years old as its matched control. So in this way, we select, for example, 100 cases. For each case, we have a matched control in terms of age. So they are individually matched for age in this matched case control study. This is individual matching. Sometimes we do group matching. In group matching, for example, if we want to study lung cancer, and lung cancer happens in elderly population, we can select our controls from actually a ward which admits elderly population. So, on average, we can see that cases and controls are more or less identical in terms of average age. Okay? So this is group matching. We do not match individually cases, each case with each control. But we select our controls in a way that cases and controls are on average identical in terms of matched variable. And so This is matching in case control studies. But when we conduct a match case control study, the way that we calculate odds ratio is different. Okay? How can we calculate odds ratio in match case control study? In match case control study, especially in individually matched case control study, we have pairs of cases and controls. This is the first pair, which are matched in terms of one or more than one matching variable. This is second pair, number 3, number 4, number 6, number 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 9, 10, 11. Yeah? So in each pair, we should determine if the case and control are exposed or not. For example, for the first case, you see, for the first pair, you can see that the case is exposed and the control is not exposed. Okay? When we are investigating the association between the exposure and control, and we have hypothesized that exposure has effect on our outcome, this pair is in favor of our hypothesis. Okay? Because case is exposed and control is not exposed. Is it clear? We have hypothesized that our exposure has an association with the outcome. Okay? If more cases have exposure, it means that exposure has association with outcome. So if in this match pair, if the case is exposed and control is not exposed, it is in favor of our hypothesis. And if case is not exposed, like in this one, but the control is exposed, it's opposite our hypothesis. Yes? And in those cases that both, in those pairs that both cases and controls are exposed, or both cases and controls are not exposed, they are neutral. So, for matched case control study, we have a number of pairs, let's say 10 pairs. In some of them, both cases and controls are exposed. Two of them, two pairs, both case and controls are exposed. And in 4 pairs, case is exposed, but the control is not exposed. In this one, there is one pair that control is exposed, but the case is not exposed. And for 3 pairs, the case is not exposed, and the control is also not exposed. So how can we calculate odds ratio? These are neutral. These pairs do not have anything to say. These pairs, those who case is exposed but controls are not exposed, these are neutral. But in those pairs that the case is exposed but the control is not exposed, it is in favor of our hypothesis. And in those pairs that the control is exposed but the case is not exposed, it's actually opposite our hypothesis. Yes?
So the limited short breath.
The odds ratio is calculated by dividing the number of pairs who is in favor of our hypothesis by the number of pairs who is opposite our hypothesis. So the matched pairs odds ratio is calculated by dividing B to C. So this is the table. You can see that you can name those who are exposed, those pairs who are exposed, cases and controls, as A, and those pairs that case is exposed but controls are unexposed as B. In pairs that controls are exposed and cases are not unexposed as C. And in those pairs who actually cases are unexposed but controls are, both cases and controls are unexposed is D. So the odds ratio would be B divided by C. So the way that we calculate odds ratio in matched case control studies is different from ordinary case control studies. Okay? Let's look at this example. You can see the table. This is A, B, C, and D. So what is the odds ratio in this case?
18 divided by 7.
18 divided by 88.
Odds ratio is yes, 18 divided by 7, which is 2.57. How can you interpret this? How can you interpret this?
Control is unexposed. Control is unexposed and the case is also unexposed.
The interpretation is the same as ordinary odds ratio. It's the same as risk ratio. It means that exposure
Or more at risk.
is associated with the disease. It means that
2.65 times.
the risk of disease is higher among exposed, and it's 2.75
6 times.
times. Okay? So, just the way of calculation is different, but the interpretation is the same. Some important points in matching. Matched variables cannot be investigated, so if you match on a variable in case control study, you cannot investigate that variable anymore. So you have to choose. If there is a variable that you want to investigate, you are not allowed to match on that specific variable. Few variables can be matched. You cannot actually match on a lot of variables, several variables, because it slows the process of selection of cases and controls. And you have to spend a lot of time and money on the study. Matched variables should have known confounding effect. If the variable you are going to match is not a known risk factor of the disease of interest, you cannot leave controlling that variable for the analysis. You do not need to match on that specific variable. And sometimes there is overmatching, which means that if you match on one or more than one variable that are related, that are correlated to the exposure of interest, you may make cases and controls the same in terms of even exposure of interest. So if there is any association between exposure and outcome, overmatching do not allow you to identify that association. So overmatching should be avoided by matching on just known risk factors of the disease and a few risk factors. One or more is okay. But more than 2, 1 or 2 is okay, but more than 2 is not okay. So just most case control, matched case control studies match only on one important variable or 2 important variables. So it is very important to avoid overmatching in case control studies. And the last point, so the first step was selection of cases. The second step was selection of controls. We saw how we can match cases and controls, but after selection of cases and controls, we have to measure exposure of interest. It is very important because we have to ask cases and controls about their exposure in the past. So recall may be an issue. Some people do not remember if they have exposed to specific exposure, for example, 10 years ago, 20 years ago. So recall is very important issue for measuring the exposure of interest. If cases and controls are identical in terms of the extent of recall problem, so it introduced a bias, but it is not a serious problem. But if cases remember better than controls, because sometimes there is cases actually detail fast about the exposure, about what they have did to actually to got sick. Okay, so they may have better memory than cases, than controls. So if there is difference between cases and controls in terms of how they remember their exposure in the past, there would be a serious problem. And actually we should have objective measure to make sure that cases and controls remember actually with the same accuracy their exposure in the past. Another problem which is very common in exposure evaluation is interviewer bias, which means if I am going to ask cases and controls about their exposure, if I am going to measure the actually exposure, if I am aware of the hypothesis under study, I may actually evaluate cases and controls differently. Maybe actually I evaluate cases better than controls. So this actually would be another bias in case control studies, which is interviewer bias. We can blind interviewer about the hypothesis of interest. Sometimes we can actually we don't say the interviewer that who is the case, who is the control. So he or she measure the exposure in the same way for both of them, and we blind interviewer in terms of actually caseness or the hypothesis of exposure. So case control study is an observational study. When we cannot do a cohort study because we do not have enough time and money, we still have an alternative, which is case control study. In case control study, we cannot calculate risk directly, but we can calculate odds ratio, which is a good estimate of risk ratio if the disease of interest is rare. This is the summary of case control study. And there are 3 steps: selection of cases, selection of controls, and measurement of exposure. If it is done actually appropriately, it's a very simple and fast and rapid way to estimate the association of exposure and outcome. Thank you.